and recording. Let me just get this off the screen. So today it's my pleasure to introduce Professor Peter Klimek from the Complexity Science Hub in Vienna, who's also a professor at the Medical University of Vienna. Professor Klimek's expertise is in complexity science, data science, statistics, and physics, and his research aims to improve our understanding and ability to predict complex socioeconomic systems ranging from human disease over healthcare systems to economic and financial systems. Peter and his research team developed prediction and stress test models for how people acquire more and chronic disorders as they age, how healthcare systems cope with changes in their workforce, and how shocks disrupt economic and financial markets. So it kind of ties up nicely with the first lecture in the series by Professor Jessica Jeffert. Peter had invented a novel statistical test to detect signs of electoral fraud and was the first to mathematically prove that governments are bound to become ineffective over time, which we've definitely had experienced. He co-authored a textbook on the theory of complex systems together with Stephen Turner and Hanno, and operated a model used by the Austrian government to forecast COVID-19 epidemics in Austria. Peter was awarded a PhD in physics in 2010 and a Venia Docendi in computational science in 2018. He's author and co-author of more than 90 publications, presented at more than 60 conferences and invited lectures. In 2021, he received the Paul Wolfslowick Ring of Honor. I hope I pronounced it properly. And in 2022, he was elected the Austrian Scientist of the Year. Okay, so please join me in welcoming Professor Klimek, and it's our pleasure to have him with us, hopefully physically sometime soon.
Thank you, Sarah, for the kind introduction, and thanks also for the possibility that I can use the seminar to tell you a little bit of our work. I will mostly talk about our efforts in applying complex systems thinking as it relates to medicine and healthcare. Yeah, but I'm happy to talk about the other stuff. Should there be another opportunity? Okay, so. Why do you need to consider a healthcare system as a complex system? And I think this picture now on a very top and broad level summarizes the problem that we're dealing with in many respects when we're talking about human disease. And the problem has not to do with floods, but the problem has to do with how evidence is generated. Because what typically happens in clinical research is that we do clinical studies in order to generate information. So if a certain drug works or if a certain thing is a risk factor. And what this means is that very typically in clinical research, you have to make a lot of assumptions where you try to constrain the patient population that you're looking at. But this has some consequences. So this is well described that there are some severe biases between the patients that are used in clinical research, so that generate our knowledge about human disease, about what kind of treatments work, and between how actual patients look like. And this here is the beyond the cartoon, the more concrete thing, how it looks like. So for instance, here it was compared diabetes patients, how they look like in real diabetes patients that show up in the hospital and diabetes patients that have been enrolled in studies. And what they typically find, to summarize the shorts, this plots here shortly, is that people that are in the real patient population, they have typically older individuals. They have typically more diseases. They are multimorbid. But these diseases have a lesser degree of severity than those that are enrolled in studies. Or to phrase it differently, those patients that we have in clinical studies, these are very often, more severe cases, very specialized cases, because also women are underrepresented in clinical studies because women have 3 hormone systems, men just have 1. So you don't want to have women in your study because they could become pregnant and then you can't follow them up anymore and so forth. So a lot of biases basically are responsible for this, that much of those that we look into how we do clinical research, that we're looking at patients that look very, very dissimilar from that where the real patients are. And one thing that we will stay with us through this presentation is how we deal with this multimorbidity issue, namely the fact that actually there is no such a thing as a diabetes patient, but very often we have patients that have a health state that is characterized by many diseases. And the reason for this is, and this is why we need network thinking, why we need complex systems thinking in medicine, because diseases are, of course, to a large extent a network effect. And the challenge is that these networks are separated across different scales. So starting from cellular processes, or the omics layers and bioinformatics, things that are going on that happen on a molecular level. But then, of course, we have networks of drug-disease interactions, networks, but also networks that are more on the macro scale, like social networks, of course, if you look about, if you think about infectious diseases, institutional networks, patient flows, that determine how good the healthcare system does its job in delivering care to these patients. Of course, this also has influences. And the aim in network medicine is that we understand how these networks look like, and particularly what happens when something goes wrong in these networks. Okay, so this you can also quite easily anticipate from what you're seeing here. So since these are all multi-layered interconnected networks, if you have something going wrong on this, on a single defect on one of the layers, this may percolate to other regions of these networks, and that's why it can happen that's why it's more norm than exception that people that patients have multiple diseases. Anyhow, so the aim that we have here is to understand how these networks look like and how we can repair or manage them. I mean, that is the overarching aim. Medicine was always about these networks. It will always be about these networks. What is now new and why this now becomes interesting is because now, for the first time in many regards, we have good data for many of these layers. So that means we can start to formulate data-driven network models for these layers. And actually, my whole presentation will consist of that I walk you through a couple of examples where we try to build this such data-driven network models for individual layers, or then it becomes more interesting for multi-layer approaches where I seek to combine information from such different layers. Okay. So multimorbidity is an issue here. Why? Because, as you know, there's such a thing as a genotype-phenotype mapping, where I can have everything from single mutation causes no change in the phenotype, causes one change, or causes multiple changes. And as it turns out, that particularly for patients with chronic disorders that are multifactorial, so if you have a situation where multiple factors are involved in a disease, then many defects on different layers that may occur, and that leads you to the consequence that you have very heterogeneous health states or disease states. So we will look a bit closer into this kind of mappings now in the talk. But first, here's just some data to get you an idea what the problem is. So these is data from Austria. I think most of the data that we're going to look at today is either from Austria or from public sources. And there we just did a very basic analysis and showed how many different diagnoses do we observe in patients over 2 years. So if we're talking about diagnosis here, most of the time I'm talking about reasons why people went to the hospital. And then for the hospital to get reimbursed, the hospitals keep a record. And these records you can then analyze. And in particular in Austria, it's the case that almost the entire population has universal. We have universal healthcare with a social insurance system that captures almost the entire population, and then we can make this population level analysis. So here are histograms that tell you how many different diagnoses we observe in all Austrian patients now taking over 2 years. So this is double logarithmic plot of the cumulative distribution. And what you see here, so here's the number of different diagnoses. You see different age groups and different sex groups. And basically, what this plot tells you is that about amongst the elderly, so 50, 60 above, it's that more than 10% of the population have more than 10 different diagnoses. If you just look at the mean value, then you see that this sharply increases with age. So you have between 1 and 2 at an age around 20, 30, but then it increases superlinearly towards older age. Actually, if we would continue this plot and for even older age, it would start to go down again because you have a survival bias. That's a different story. So anyhow, so very skewed distribution. So here for the elderly, you have average number of diagnoses of 4 or 5, but you have you have many individuals that have way more than 10 different diagnoses. And here we look at this in more detail for diabetes patients and also count how many different drugs they take, because this is the next thing. If people have multiple diseases, they have multiple drugs. And so we find a sizable number of individuals that have like 50 different diagnoses and are treated with 60, 70 different drugs. And this means that there is really no such thing as a diabetes patient, if you want. So typically you have different types of patients that also have a diabetes diagnosis. And this we try to understand. So for those of you who don't have, are not familiar with prevalences of different diagnoses, so non-communicable diseases are actually the leading cause of death worldwide. So of course, we talked a lot about COVID in the last couple of years, but actually the highest disease burden and the highest death burden, of course, comes from non-communicable diseases. We're talking here about 68% of all mortalities, and out of those are 40% pre-major. These non-communicable diseases, we're thinking here about cardiovascular diseases, cancer, COPD, diabetes, and so forth. And as already said, what many of these diseases have in common and why we need this network approach is because they are often multifactorial. That means it depends on many different factors, starting from the genetic background, but up until lifestyle, environmental influences, whether you get them or not. Okay, so now let's start to look into different layers of this multi-layer network that determine our health at the end of the day. And what is in many examples one of our working horses is a disease network or a comorbidity network. And this is what I now want to briefly explain you what we mean by that. So we need some mathematical language or some formal language in order to describe how patient states actually look like, and to learn the patient states from the data. And I will now walk you through how we think this can be done from this kind of data, particularly in an explainable and interpretable way. So disease network, it's quite trivial. Networks, as you know, are collections of circles and lines. So let's say we look at our hospital patient population. So there we have about 2 million hospital encounters for 8 million patients in this data set, and identify those that have a diabetes diagnosis, identify those that have a different diagnosis than, let's say, pancreatic cancer, and we try to overlap we quantify the overlap. There are different ways of doing that. I will briefly touch upon what the methodological issues are here. But the idea is that we map this to a network where the nodes are then individual diseases or diagnoses. Links mean that 2 diseases tend to co-occur in a patient, and the size of the nodes will be the disease prevalence. So methodological issues. Of course, all these relations, they strongly depend on age and sex. We've already seen that, so you need to make adjustments for that. Then just let me briefly point out that what we are dealing this, and this is not only, of course, in the context of disease networks, but this applies whenever you construct correlation networks from data, that what you're looking at is a massive multiple hypothesis testing problem. So if you if you use statistical networks to construct links, you need to think about how you can control the false discovery rate or any other statistical entity like the family-wise error rate. So this is one issue that the network analysis is sometimes overlooked. And what is also sometimes overlooked is that it's even worse than this multiple hypothesis testing problem. So this is what in statistics, there are standard measures for that. Bonferroni correction is the simplest one, or Beniamini-Hochberg correction. But if we do statistics on networks, then we often face a multi-scale problem. So what is that? With diseases, but also in many other real-world applications, the situation is that you have events, that you compare events of completely different frequencies. So for instance, the most frequent diagnosis is hypertension that affects about 5 or 10% of the population. But then you have rare diseases that only affect 10 patients at all. So what you're trying to do in these disease networks, but also in many other correlation networks, is that you try to measure associations on one scale between very rare and very frequent, or two very frequent, or two very rare events. And there are ways of dealing with the statistical problem. This could be a whole lecture on that. So the most famous, maybe one of the first meaningful algorithm of solving this problem was the disparity filter. But what I'm saying, different ways of approaching this issue. But point is, you need to somehow address this problem. Otherwise, you will end up with nonsensical or hairball networks. So let's assume you do this all properly. Then I can briefly show you here how these comorbidity networks then look like. So again, here we are looking this for females and males, and we look at this in different age groups. And here the nodes are diagnoses, and again the links mean that two diagnoses tend to co-occur, and the colors here are different types of diagnosis. So for instance, if you look into the comorbidity network of patients aged between 0 to 8 years, so small children, then you see that what you frequently have here are this blue diagnosis here. These are diseases of the respiratory system. So these are all the respiratory infections that children have at younger age, like RSV. But of course, it's also the most frequent here is if children go to the hospital to get their tonsils taken out. You have epilepsy, you have other kind of viral or bacterial infections. Those are the green ones, and you have phimosis for the boys. But otherwise, you see that large chunks of this network are you have isolated nodes, so there's not much going on here. If you go to patients aged 9 to 16 years, you see that the network becomes sparser. So these are typically the age groups where patients are at the healthiest, at least where they show up least often in the hospital. And if they show up, then what you see here is that we have now a cluster of nodes appearing, which contains mental and behavioral disorders. So what does this mean? This means typically a health state of a 15-year-old male or female patients might be characterized by that you have a substance abuse disorder like alcoholism, or combined with schizoaffective disorder. And this is what it means that you have these clusters here. If you go to 17 to 24 years, you have here the diagnosis of genitourinary diseases emerging. You have still a cluster of mental disorders. You have a cluster of digestive disorders. By the way, this cluster of genitourinary diseases, so these are like urinary tract infections. This mostly affects females, not so much males. This is, of course, to do with sexual activity, and is a sign that boys should wash themselves properly. In any case, the fact that you have these disconnected clusters mean that it's very unlikely, or not at least statistically overrepresented, that you will have a patient in the hospital with a depression diagnosis and at the same time, say, gastritis or a disease in a different cluster. 25 to 32 years, now diseases of the musculoskeletal system appear. 33 to 40 years, now we have cancers appearing. So these are like breast cancer for females and prostate cancer for males. 40 to 48 years, if you've had an unhealthy lifestyle, then now it's payback time. This is where the metabolic syndrome starts to hit. So these are these yellow and orange diseases here, that dyslipidemia, hypercholesterolemia, hypertension, overweight, diabetes. And of course, if you have these metabolic diseases are a risk factor for cardiovascular diseases. So then out of this cluster of metabolic syndromes, you have the cluster of circulatory or cardiovascular diseases appearing actually more frequently for males than for females. And if we now get to elderly patients that are in this regime that I've described before, where you have on average 5 diagnoses and you have a sizable number of patients that have more than 10 different diagnoses, then you see that the structure of this network has substantially changed. So now it's not that you have isolated clusters or more or less well-separated clusters, but instead you have the emergence of hubs. And these hubs are these chronic non-communicable disorders that we mentioned before. Here you see them spelled out. So you have heart attack, COPD, diabetes, everything related to the metabolic syndrome and so forth. And these diseases by themselves may not, of course, they are a disease burden, but it's still a burden that you can manage. And which you can only manage, by the way, because most of these diseases you can't heal. But the fact is that what makes them on a systems level problematic is that they are risk factors for literally dozens of other diagnoses. And these other diagnoses are then where the quality of life and everything suffers more severe. And yeah, okay. So this is how basically these networks allow you to find a description for how these health states look like, at least to on a first order level, where we'll just look into correlations of two diagnoses. Well, what are they good for other than that you can draw beautiful pictures on? Well, what we've just seen when looking through these networks, how it changes over time, is that patients acquire those diseases that are in close network proximity to the diseases that they already have. And this is the reason why this thing has on a formal level some value. So here is a very simple ansatz that where you try to express this mathematically. So there we look at the frequency of patients that are male, female of a certain age, and you look at the prevalence of a disease I. And the ansatz is simply those that have the likelihood or prevalence of having this diagnosis in age group A+1 is given by the probability that you've already had this in the previous age group. And if you haven't already had this, then you basically collect the network risks. So you read off from these networks, you read off how likely is it that you observe them, given that you have this diagnosis, that you observe another one. And by this, on the population level, actually this describes it rather nicely or already quite well. What is the frequency of diagnosis that you have to expect in the next 10 years? I think we evaluated here. However, what this is much too coarse is to make any statements on the individual level. To do these predictions on an individual level, you have to put a little bit more structure into these models. And basically one way of doing that I'm briefly showing here is that you go into higher order relations. So you can think of this, if you build this network model, actually what you then do is that for each diagnosis, you have risk factors that are other diagnoses. In the next higher order interactions, your risk factors are not single diagnoses, but combinations of diagnoses. So combinations of sets of 2, 3, or 4 diagnoses that co-occur in a single patients. And this is what we evaluated here in this work as a prediction task. So we observed the combinations of diagnoses that they had in a certain time period, and then used this to predict using a multinomial naive Bayes classifier which diagnosis they will get in the future. And so here's the visualization of how this higher order features look like. But basically, for instance, if you try to predict depression, then the single features, so that you just have one variable that gives you the highest information gain in predicting depression, is knowing whether the patient already has had an alcoholism diagnosis and the sex. If you then go to higher order interactions, then it might be a combination of these factors. So like that in the algorithm, we treat a male alcoholism diagnosis different than a female alcoholism diagnosis. And then you can go to the third level, where you combine, for instance, sex with, in this case, F10 would be, again, this alcoholism diagnosis, plus other diagnoses like hypertension or a nicotine dependence, a likelihood of accidents, and so forth. So, of course, you have to do some item set mining, some feature selection, in order to feature engineering, in order to know in which kind of this higher order motives to look at. But of course, there are methods that allow you to pick them out. And the main result is then summarized here. So what you see here is a precision recall plot. So a precision, this means that is the probability that if you make a prediction that a patient will get this diagnosis, that it is true. And the recall, that is the probability that the disease that then occurred, that we actually predicted that disease. And what you're interested in, so the optimal algorithm is of course here, so that both of these measures are 1. And the turquoise points, the bright points here is level 1, so just meaning individual diagnosis. And as you see, for most of the diagnoses, the precision is quite low, around 20%. That's what I said before. On the population level, these networks make some sense, but on an individual level, they are too coarse in order to describe the patient states. However, if you then increase the order and include more complex features with more diagnosis, then you see that for some diagnoses, you have huge gains in precision while not having reductions in the recall. However, you also see that for some diagnoses, you simply can't predict them from that kind of data. But anyhow, so here, this is one way of approaching the question of learning patient phenotypes from data into looking at these higher order interactions. The next step is to look into more closely resolved trajectories. So right now, so until now, we just looked into what are different states in terms of co-occurring diagnosis. And now the next step is then, so then we've seen, okay, they have some predictive value for which diagnosis will come next. And now the next step is that we put this together and say, okay, so now what are now trajectories people undergo as they age from 0 to 90 years? And this is here an outline of an algorithm or pipeline that we developed in order to deal with this problem. So the data basically looks like this. So you have here, you start from a data matrix where you have patients. These are the rows here, and the columns are whether they have a certain diagnosis or not. And so at this given year, then the population is described by a matrix, patients times diagnosis. If now from one year to the next, this diagnosis may change, and then that means this matrix gets updated. And what we do with these matrices is that we cluster them using an interpretable algorithm. That's the diff+T algorithm. And what you do there basically is you build a very simple decision tree where you ask whether certain diagnoses are present or not. And so, for instance, the first question that you ask is, does this patient have hypertension? Yes or no? And depending on whether the answer is yes or no, then you ask next a different diagnosis. So if the patient has hypertension, then the next question you ask is, does he or she have diabetes? Yes or no? And you always pick a question that you ask that reduces you use Watts criterion, so basically that gives you the highest information gain when asking this question. So the clusters are then basically such sequences of, if you follow then one branch in this tree, up until you stop asking questions using a cutoff criteria, then this is what you call a cluster here. Then, as I already said, as patients age, the answer to some of these questions might change. So, for instance, the patient up until a certain year hasn't had a diabetes diagnosis, so he was in cluster 2. Then diabetes gets diagnosed, and then you jump to cluster 1. And in that way, you induce a transition network between different clusters, and this is then how this looks like. So this is what you see here is basically how we think of then health states in the entire Austrian population. So these networks here these nodes here are not diagnoses anymore as we had it before, but they are now this clusters of diagnoses that mean a combination of any number of diagnoses that co-occur. The color here of the links is the age, so they are youngest here, and then as they age, you go from left to right in the network. The color of these clusters here is the mortality risk, and then you see that here when they are the eldest, then here you have the highest mortality risks. However, you have also regions in the network where people are also elderly, but you have a much lower mortality risk. So the question of healthy aging is then the question to define which are points in this network where you still observe that people can avoid ending up in the regions here where, particularly due to cardiovascular diseases, mortality is very high. And this is one of the ways that we think about approaching more tailored methods to design interventions and to know whom to screen and which are risk populations for certain diagnoses in order to identify these trajectories that get patients towards such high risk states as early as possible. Okay, So now let me come back to this layers that I introduced before. So right now we just looked at this diagnosis, and I basically showed you that using this disease network formalism or some more generalist version of that, basically you find ways in order to get a quantitative hold of more complicated patient phenotypes. I mean, that have some predictive value. And now, in order to do anything meaningful with them, other than prediction, it becomes, of course, interesting if you link those with other data layers. And one obvious candidate is because, as I said, having multiple diseases means that these patients typically receive multiple treatments. So the standard situation is that patients are treated with a certain drug, and this drug can lead to side effects. And this is, of course, what you want to minimize. So a concrete example would be diabetes. And patients with diabetes have a higher risk for cardiovascular diseases, as we've already seen. So they very often take statins in order to prevent this progression towards more cardiovascular diseases. But at the same time, all of the therapies for diabetes also are involved in a different role in leading to comorbidities between diabetes and cancer. So to make this more concrete, so there we looked into what are the different types of diabetes treatment that we observe in the Austrian population. So here we're talking about medications, and how do they affect these profiles of side effects. So to make the dimensions of this problem clear, so in diabetes treatment, there are at this level 17 different medications that are relevant. So this is like insulin, but also oral antidiabetics like metformin, DPP-4 inhibitors and stuff like that. Out of the 17 relevant medications, then of course 2 to the 17 possible combinations could occur in the individuals. However, what you actually observe are 300 different combinations of diabetes drugs that occur. And now you can, of course, use such network approaches in order to analyze how do these combinations influence cancer risks. And what you find is that, so for instance, insulin as a monotherapy, so if patients just relieve insulin, then of course that helps for diabetes, but you have 10-fold increased risk for pancreas cancer, 7-fold increased risk for cancer to peritoneum, 4 times for brain, and so forth. This is well known. Insulin is a growth factor, so it increases the cancer risk. Also metformin, first-line treatment oral antidiabetic, has 2 to 3-fold increased risks for cancer at certain localizations. However, if you combine insulin with statins, then we find that you basically can offset this insulin-related cancer risk and go to reduced risks for cancer in these groups that are treated that way. So if we talk, you might have heard a lot of talk about personalized medicine and individualized medicine and the need that we develop treatments for individual patients. I would say one way to think about individualized and personalized medicine is not to develop new treatments, but to learn from data which combinations of existing treatments work best for one specific patient with one specific set of pre-existing conditions and a profile for different complications. Okay, so I'm also looking shortly into how this relates to healthcare utilization. So the point is, we've talked about these disease networks here, but there basically one node was standing for a hospitalization due to a different diagnosis. But of course, you can ask that maybe we can treat the patients before they end up in the hospital. And this is what we did in this work. And there we asked how the risk of this association here, how this depends on whether there was a contact with a physician in between or not. And so there we combine this disease network with the patient flow network and basically ask if between these two diagnoses, if you had a contact, how much does this decrease the weight of the risk? And long story short, what you find is that particularly for chronic diseases, we find the strongest reductions for these readmission risks up to 50%. And overall, males have had a higher readmission risk than females. That has to do maybe with the fact that males are more reluctant to seek treatment at physicians, and then they end up in the hospital with higher degrees of severity because they are more reluctant to get the treatment early on, at least than females. Yeah. So this means if you get a doctor appointment, go there. It really it reduces then on the longer term really the chance that you will then end up in the hospital with a more severe disease if this physician contacts are taking place. Okay, I briefly touch about how this relates to everything that goes on under omics. And because right now I haven't told you anything about why certain two diseases might be connected with each other. And this is, of course, not an easy question, and you can't, there's more than one answer to that, as diseases are multifactorial. But one way of thinking about this can be summarized as following. So assume we have here our disease network, and two diseases, I and J, are comorbid. Now, also assume that you have a mechanism B where you know that this is involved both in diseases I and J. So it could be a single point mutation in the gene, and where it's then recorded that this has something to do with this disease and with that disease. Assume that you also know a different mechanism for disease I, one that is involved in two other diagnoses, so in I and K. And the strength of this link should tell you how often this co-occurred. It means here you have a patient phenotype that consists of the co-occurrence of I and J, and this is nicely explained in mechanism B. However, the phenotype that you would expect from mechanism A, namely the co-occurrence of I and K, this is less frequently observed. So this is the main idea in order to explain whether you find some mechanisms that explain you the comorbidities that you observe. And here is this, if you do this a bit more systematically. So in this work, we looked at 3 different layers where the mechanisms are encoded. One is the genetic layer. So here we look at single point mutations. One is a pathway-based layer, so where two diseases are related if they're both related to the same metabolic pathway. And the third type of interactions that we included here are toxicogenomic interactions. So this is one chemical like nicotine or some environmental pollutants are known to induce genetic changes that are then in turn related to the diagnosis. And basically the question that you ask here is, if you look at this comorbidity network, so the phenotypic comorbidity network, how well can you explain this network with how well can you explain the comorbidities of a diagnosis by the comorbidities that you observe in these different data layers? And what you find when doing that is that most of the diagnoses actually fall on one axis here. So the axes here belong to the different layers. So we appear the layer for genetic relations, for pathway-based, and for toxicogenomic relations. And actually what you observe is that most disease risks fall on one of these axes, meaning that the comorbidities can be explained by one type of mechanisms very often. And there we also, of course, made sure to just include diagnoses where there is some information on all of these layers. So this allows you to somehow answer how non-genetic, at least, is a diagnosis, because as you see, while most of the diagnoses cluster here along the genetic axis, we have also diagnoses that are completely orthogonal to this axis, and where this genetic information gives you very little or allows you very little to explain the phenotypes that you observe. And it turns, so this you can formalize into an index. We call it here the nurture index, where we put this non-genetic contributions into a single indicator. And what you find is, first, as a proof of concept, that the lower this indicator, the higher the heritability of the diagnosis. But which is maybe also relevant is that the lower this indicator, the less drug approvers are for these diseases. And our view, this hints at a systematic bias that we have in pharmaceutical research, that we're not good in bringing drugs to the market if for diagnosis where this genetic dimension doesn't play a role, and where maybe all this information that is recorded in these databases doesn't really tell you much about the phenotypes that you actually observe. Okay, moving on, institutional networks. As I've already seen, health states are also influenced by how patients flow through the networks of care providers. And an ideal example of how such a patient flow could look like you see here. Starting if you get sick, you first go to a GP, a general practitioner, a primary physician, then maybe get sent to a specialist, then pick up something at the pharmacy, and hopefully you don't have to go to a doctor anymore because now you're cured. Maybe more realistic is if something like this happens, so you go to one doctor, then it doesn't work, you try another doctor and so forth, and run circles in the healthcare system. And if you draw this network for all of Austria, then it actually looks like this, where you see then, so these are basically for Austria, which is 8 to 9 million people. There's a couple of thousand doctors, and here you basically see the network that they span. One thing that we do with these networks is that we use them to stress test the system. So here these doctors have been put on a map. So for instance, and this is now, for instance, the path of one single patient, how this might look like. So this is obviously the GP of this patient. And then you see the patient has different contacts, so spans up a network of doctors where he also is in contact with. The question is that we ask them there is, so since we are facing retirement waves in the physician workforce, and of course, since there are also ongoing problems with mass quarantines in healthcare workers, so what happens now if these doctors are not available anymore for whatever reason? Well, if you look at such event in the data, that what you find then is if this patient here loses his GP, then he's more likely to then go to a physician with whom he has already been in contact with. So that means you can now look into a patient sharing network across all doctors. And then you have that for this doctor, so here all the nodes are GPs. And the thickness of the line is how many patients this GP shares with other GPs. And what the data then leads you to believe is that if this doctor would retire or be not able to continue his work, the patients would tend to move to that GP. Now, this GP might have a limited capacity and can't take on all doctors, and then patients have to go somewhere else and look for a doctor. And this you can do to perform in a computer simulation a stress test, how many doctors you can take out of the systems while patients are still able to somewhere find a doctor that treats them. And what you find then is that these curves typically look like as you've seen here. So here we successively remove patients from a given state. And then on the y-axis, we plot the number of patients in the simulation that are not able to find anymore a doctor with a capacity to treat them. And then depending on the sequence in which you remove them, at one point, you will see that, okay, now patients are not able to find doctors anymore and get lost. And if you measure this entity from the model, so when is it the case that the patients don't find a doctor anymore, then this is, so to say, the tipping point of the system. So you can remove doctors up until that point, and the system will still be able to cope and deliver care to the patients, but it's beyond this point, this will not be able anymore. And as you see, these tipping points are highly heterogeneous across different regions. So this is really a regional property that, by the way, has also as we've shown in that paper, that are not a property of just of the physician density, so of the number of doctors per capita, but it's really a network effect. So since patients don't access physicians at random, but through networks of patient flows. And this basically you can then repeat for different federal states, for different for different regions, for different care providers, and compute this kind of risk scores. And we think that this stress testing healthcare systems in that way is something that will become more and more issues moving forward as we have mounting pressures on the healthcare system, both from the disease side, but also, of course, due to fiscal constraints that the systems are more and more under budgetary constraints, and so this is something to keep an eye on. Okay, the last part of this talk, I want to touch upon our work that we do on modeling the spread of infectious diseases on networks, because starting from the pandemic, this is something that has eaten up quite a huge time of course, of our research. So we've, as Sarah also said, we've also been involved there on the so running one of the models that is used by the Austrian government to forecast the pandemics in Austria. So this is something that kept us quite busy in the last couple of years, and I want to share with you some of the results that have come forward from that. So of course, one of the questions that I think we all asked ourselves when this whole started is, now many governments are doing these drastic interventions, and how can we measure whether they are effective or how effective they are? And this of course was quite challenging, because in the beginning, many countries implemented many measures at the same time, so it becomes hard in order to disentangle the different effects of an individual measure. And one of our colleagues, Amélie de Vallarif, was one of the first to start building a tracker, so a collaborative effort in order to categorize and document which NPI, which non-pharmaceutical intervention, was implemented in which country at which point in time. And so what we then looked at the end are multiple databases where we had thousands of implementations of NPIs in about 200 countries. I'm now focusing on one of those, and for now, for this now, let's start looking just at the very first period, March and April 2020. So one of the issues that you have in this analysis, it's that it's far from trivial how to approach this methodologically. And as you know, these models are all quite sensitive, and modern disease spread is quite sensitive. So a lot of your results can be really susceptible to the choices of methods that you do. And in order to deal with this problem, what we did there is to look at 4 different methods and try to establish consensus across these methods. So to keep story short, what the idea was that we basically correlate when an NPI was released across different countries to correlate this with the time-dependent effective reproduction number, RT. So that is at a given time point, the number of infections on average caused by an infectious individual. And this we did using 4 different methods, or 4 different modeling approaches, 2 regression approaches. One was a lasso approach, and one was basically a case control study design, and then 2 machine learning models, one a shallow learning model and one deep learning model. And as I said, since this is also context dependent, you need different layers of validation. So of course you can do validation within a model, like cross-validation. Having 4 different approaches allowed us to do a comparison of the results across different models. And of course, we also had these different data sets to compare findings across different data sets. And here's the effectiveness ranking that we produced. So let me briefly walk you through that. So on the y-axis, you find, on the x-axis, you find the reduction in the effective reproduction number that is associated with an NPI. The NPIs are then listed here in the lines, and the colors basically briefly tell you which type of NPI this was. Here you see the results from these 4 different modeling approaches. So if there is a red square, this tells you that this NPI by this specific modeling approach had a significant effect. And this then allows us to identify those interventions that had a significant effect in all of these models that we looked into, or at least in 3 of them. The result of this, maybe not surprising, most effective is if you close everything where people meet in smaller groups for extended periods of time. So these are the small gathering cancellations. Maybe a bit more surprising, at least in the very early phases, was the huge effects that we associated with the closure of educational institutions. This was, of course, particularly the case in the first wave, and this is also in line still with systematic reviews on this issue. Also effective were border restrictions, measures to increase the availability of PPE, or in general the public health capacity, movement restrictions, including lockdowns, of course, and mass gathering cancellations. But after these methods, most effective are already risk communication efforts, and they were distinguished between those directed at the public and those at specific stakeholders. And of course, basically, you need to have both. Yeah, but as you see here, I mean, the effective reproduction number is basically an exponential growth rate. So this uncertainty intervals that we have here, they are quite broad. So that means the effectiveness of one of these measures was, even though some are always showing effect, the size of this effect, the magnitude of this effect differs quite substantially. And there's, of course, a good reason for that. I would say there is no such thing as the effectiveness of a single intervention at all. This always depends on the context. And the context is, on the one hand, timing. So here is a sub-analysis where we show how the effectiveness depends at the time where the measure was adopted. And there you can have different patterns across different measures. So some become more effective, some less effective, depending on when at the epidemic wave you implement them. But of course, context also means properties like socioeconomic factors, cultural factors, but also actually the whole trajectory of NPIs that you've already had. So yeah, effectiveness of NPIs you always have to evaluate in context. One of the results that of course puzzled us here was the strong effects we found here for schools, and this of course has then also been repeatedly confirmed in other studies. And as you know, there's still a lot of discussion around this, whether so what exactly is the involvement of children in the epidemic spread of SARS-CoV-2, and also what are the consequences for this for schools. And in order to understand this closer, in the next work, we tried to understand the spread in school, in educational institutions better. And here you see results from Austrian contact tracing data. So these are for different school types, the distributions of cases across different clusters that we observe. So here are the percentage of outbreaks with one follow-up cases, 2 follow-up cases, and so forth. Basically, you see that most of the clusters are small, but you have a non-vanishing probability that you also get larger clusters. We used here an agent-based model in order to, which we could then calibrate using this kind of cluster tracing information. So here you have again the size distribution of the clusters, but also for the clusters, whether they were initiated by a student, by a student or by a teacher. And this together with information on exposure duration, incubation times, etc., all these things that come up in epidemiological modeling, we could then basically formulate such a model where we, on the one hand, have this, as close to the data as we manage to model it, how patients progress from susceptible to exposed to infectious to recovered. But this also linked with an in-host viral kinetics model in order that we can analyze at which point people test positive, for instance, and in order to gauge the effectiveness of different testing strategies. A lot of things that could be discussed about this. I just want to focus one thing that is, I think, particularly relevant for network thinking and why networks are important in this context. So as I mentioned, there's still a lot of confusion often how much children actually contribute to the disease spread and whether it's physiological difference or whatnot. And what we look here at is the typical contact network that you have in a primary school in Austria. So the red nodes here are the students, and they form a class. And of course, people in the class have contact with each other. The blue nodes are the teachers, and one teacher is typically there for one class. And then the gray nodes are household members. Then, of course, occasionally you have it that you have parents that have children in 2 different classes. So they form bridges between these classes. So this is how the typical network in a primary school looks like. This is the typical contact network for a secondary school. Of course, completely different networks, much larger, much denser. You have teachers that go in each hour into a different class. And of course, this epidemic spread on this kind of network looks completely different than the network that we have previously looked at. And actually, after calibrating everything properly, we found that with a combined effect of these different networks and the fact that with younger age you're less likely to be symptomatic, but that basically this explains the observed differences in incidences between as a function of age. So it is an effect of surveillance and an effect of the networks. Okay, so we use this model in order to then evaluate different combinations of measures, and also, to make a long story short, particularly for Delta, but then also for the Omicron variant, we find that one intervention alone, so just tracing or ventilating or masking or student cohorting or regular testing, that one layer alone won't be able to really avoid larger outbreaks. However, if you combine and stack these layers on top of each other, then you have a chance of at least reducing the likelihood of these very large outbreaks. And yeah, basically the same simulation model was also applied for nursing homes, and there we consulted with a couple of nursing homes in order to design testing strategies for them, but they are the same principle holds. So you also have to stack these intervention measures on top of each other and to get into something like a protection. Okay, so the very last thing that I briefly want to show you is, so we talked about the effectiveness of NPIs, but still there is often a discussion what these measures are really good for, or if it's not all seasonality or maybe pure chance which drives this fact when waves come and go. And we try to look a little bit closer into these questions by a modeling approach that you see outlined here. So that here is we look into one district for each of Austria. For each district, we have different input time series ranging from weather, so different so temperature, humidity, etc. Restrictions, so the NPIs on a regional level, and via collaboration with the telecommunications company, mobility as derived from aggregate cell phone use data. And what you can then do is to look into a single district and compare this with surrounding districts, and then see what were the regional differences that you observed in the epi curve in one district from its surroundings, and whether you can explain these differences with these effects. The modeling approach goes like this, but to keep their things short, the idea is basically that's a compartmental model in which you measure the transmission rates. Basically, you can estimate backwards from the known case data, and then you assume that these interventions acting multiplicatively on this transmission rate, and then you calibrate. So you use a nonlinear solver in order to solve the model for this effect sizes. What you end up with is briefly summarized here. So here are the different effect sizes for weather times, for weather, for restrictions, for mobility. And for this question whether it's randomness or seasonality or whatnot, long story short, so from these regional differences that we observed in Austria, whether the wave was high or not so high, about 60% of those differences we could explain using this model. So 40% couldn't explain using these factors, or maybe we could explain them if we use a smarter model, but this is at least what we managed to get to, 60%. Out of the 60%, 15% are meteorological variables, and 35 to 45%, depending on how you count this, are by NPIs. So yes, there is, of course, an element of randomness where the virus tends to pop up earlier. Weather obviously plays a role, but still NPIs, and that means the activities and the things that we do matter more than these facts. Okay, and with this, I'm at the end of the talk, and I want to thank you for sticking around with me. So take-home messages would be that I hope that I've been able to show you that this kind of comorbidity or disease networks, that they allow us also using a mathematical and formal language to understand these concepts like multimorbidity and polypharmacy to understand them better. I think we need these developments in order to get better in structuring the healthcare system. and thinking about personalized prevention strategy and how to optimize healthcare processes, also with all these budgetary constraints that are mounting. And I really think that this complex systems and network approaches, can be combined with other things, a very valuable toolbox for something that is increasingly called precision public health. So the idea that we can use this data-informed strategies to identify highly stratified subpopulation where certain interventions, so be it NPIs in disease spread, but be it the prevention of chronic disorders, we really need to get better in identifying the risk groups in the population and targeting them with specific interventions as early as possible in order to avoid that they become sick and then cause these high disease burdens for our healthcare systems. So with this, thank you for the attention, and I'm happy to take any questions that you might have.
Thank you so much, Peter, for this beautiful walkthrough from the comorbidity network all the way to institutional and network and the stresses in healthcare. So we'll start by taking questions from the audience, and we have also audience on Zoom. Please, if you have questions, please raise your hands or write your questions in the chat if you'd like to have it written. But I'll start with the crowds in the auditorium. Questions? Maybe I'll start with the question. When you looked at the transition of the network to, or the evolution of the network with age group for the comorbidity network, and so it's sort of reached a steady state, right, with age, and it was no longer differentiable between the male and female sexes. So did you look at the topology of that network, the onset of that transition as a function of topological measures?
I mean, of course, yeah, you have something like, so you see, of course, this transition from basically a small word structure to something that is more like scale in the sense that it is hubs. I mean, the network is too small to really talk about scaling, etc. But yes, there is a transition point when you can see this, of course, in some of the network observables. Just a brief note, I mean, there are also still differences between males and females. We evaluated this in a couple of follow-up papers, but it's just that those then, you don't see them just on the simple network pictures anymore, but of course there are, so for instance, the given certain metabolic diseases, females, so females typically are, to put it simple, are also in the older age groups. If they are healthy, they are healthier. But if they have some metabolic diseases, they have a higher risk for certain follow-up diseases than males. So with females, we see, so to say, a huge spectrum. So they are either healthier or they progress faster, and males are on average unhealthier but don't progress as fast. So I would so maybe you can briefly summarize this. And yeah, and concerning the topological properties, yes, as I said, depends on what you. I mean, of course, it's all, as it also described, you have to do a lot of filtering. So keep always in mind that how these networks then look like also depends on the choices when visualizing and filtering them. So maybe that's good to develop an intuition, but if you really want to do some modeling, or want to know if the model makes some sense of the structure, then you should, of course, compare this. You should proceed to some form of validation, and then, but then you see that this idea, so like evaluating how good the predictive performance of these algorithms are if you use different ways to construct these networks. And I think this is yeah, how this problem should be approached.
Questions? Also on, yes, we have a question in the chat. Yeah, read it up. So Gaurus, thanking you for the insightful talk. At one point you mentioned survivor bias. Could you please talk a bit about that and how it may affect your medical data?
Thank you. I left this now out, but basically I only went until 72 years. And we have much more patients who are becoming, of course, older than 72 years. And what this happens is basically, So for networks that where you go past this point or higher than 80, then what happens then is that those that had this high disease burden, they are already dead. So if you look at the disease state of 85, of 90-year-old patients, they will be more healthy than 80 or 75-year-old patients on average, because the unhealthy ones are already dead by this point of view. So how does this affect the results? Well, it depends. One is that you shouldn't make the assumption that everything goes linear with age or even monotonous with age. As you see, there are multiple turning points. So just here looking at the density of these networks, you have one turning point around age of 15, 20, and unfortunately we don't see it here, but here at 85, 90, you have a second turning point. And then, of course, it depends on which kind of analysis you're doing, whether this has an impact on this or not. What I'm saying here is that this is not really a trivial relation between age and disease burden, at least for these high age groups. Yeah.
Yes, we have a question in the chat. Shadi had been writing, but we have a live question from the audience. Maybe Shadi can follow up.
Yeah, thank you very much, Peter. Fairly complex dynamics that you described for us. I have a couple of questions. One, you described conducting stress tests on the networks, having mapped them, and you sort of went about it experimentally. But COVID surely provided a serious stress test to the healthcare system in Austria. What do you have to say on that in relationship to what you guys have understood? That's the first question. If I may ask the second question, and then I leave you to answer comfortably. A very important concern for colleagues here at the American University of Beirut has to do with occupational health and the specific diseases that are associated with occupations. Have you done any work on that? And that raises the related question of the generalizability of your work and your conclusions to other contexts other than Austria.
Yes. Okay, a lot of questions. I hope that I don't forget all the questions while I start answering them, but then just remind me again. First, stress test. So what we unfortunately we don't have yet any data post 2020. So what we've been seeing in the data that we have that goes until 2018, or that we analyzed, is of course some natural experiments where doctors just retired. So you see that they were very active up to some point, and then at one point they stopped being active and drop out of the data. And then you can ask the questions, okay, now where do the patients go that have been treated by these doctors? And then you see that it's this displacement steps on the networks, and this we then formalized as a model. So whether this has, it will be very, and we are of course now preparing to do this, to also look into this, what we have now seen during the pandemic. So all the analysis that have shown you on the stress testing part was from pre-pandemic times. So answer to your questions, I don't know, but we will look into this, and I'm very excited and so curious seeing how this how this then actually looked like, because I think the acute shock of the COVID pandemics might be over. But this post-acute thing that we will now start to understand, as it was with the financial crisis 2007, 2008, going forward, how this changed the system, and if there were some long-term behavioral changes in how people utilize the healthcare system, this will be very interesting to study, and also important to study. So, but I can't unfortunately yet answer your questions whether if there was a more concentrated shock and then this is a succession of shocks, as we had with lockdowns and with mass quarantines during the pandemics, how well is aligned with our models. But this is obviously the next question that we will ask. The other question was concerning occupational risks. So unfortunately for the Austrian data, we don't have occupations. I haven't talked about this work now, but we have done similar studies using Swedish registry data. And of course, Sweden has a very good data ecosystem, and there we haven't looked in occupation themselves, but of course you can do some adjustments for income. And again, long story short, there, of course, you see that these networks are, of course, heavily dependent on, or also to some extent dependent on socioeconomic factors. And typically you have it that it's not that poor people are sicker in this data, to make it simple, to make it formulate it easier. But of course, this is all about utilization. So you see in certain subgroups, and then the Swedish data, we particularly looked into the refugee population in Sweden, that they seemingly have a much better health state because they have less encounters with the healthcare system. So they have a higher barriers towards accessing the healthcare system. However, if they access the healthcare system, then very often you find there a higher frequency of very severe disease outcomes, which tells you maybe that these cohorts are undertreated. So from this, I would extrapolate that you get different, similar results, similar findings. Of course, via this issue that this is socioeconomically an issue of how well you can access the healthcare system, and this even in states like Sweden, but also in Austria. And I don't know any studies how this is then in countries that do not belong to the global north. Concerning comparability of these networks across different countries. So I mean that these networks exist, that they more or less look similar in the basic characteristics across many different countries. I think this has been established. There have been also been some studies from African countries where they have looked into these comorbidity networks, where you, of course, also in the Chinese population, you see a spread of Western lifestyle, and with this associated all the diseases that are associated with the Western lifestyle. So this you also see picking up in other countries. But what I haven't seen yet, and where I would also think that this is an interesting question to ask next, is, to really combine these efforts across countries more in a more systematic way. And to understand how well this relations generalize across different healthcare systems, because of course this is one of the big challenges in this analysis. You're partly seeing the health state of patients and partly seeing how the healthcare system works, and the data can be informative for both, but you need to prepare the data analysis and make the analysis properly, that you can isolate these factors if you can isolate them. So we did a couple of studies for specific questions where we combined data from Sweden with Denmark, and there we already found that these issues and biases, of course, play a role. So I think there is much to be done on that front in order to disentangle these dimensions across multiple countries. And I hope I didn't forget any question now.
Thank you, Peter. I also have a follow-up question on this issue of testing the stresses on the system. So you can even simulate more catastrophic stresses. So here in this case, you're just looking at retirements effect, but you have these general practitioners, and you can identify hubs, and you can start doing some sort of cascading node removal and measure like the stresses or the effect or the avalanches of failures over the network. So did you not do that kind of worst case scenario testing?
Actually, we do. So in this, a preprint on this will be published, should be published in a couple of weeks. I think we don't have it so clear in the first paper, which was the PNAS here, but there's also a preprint out of this. But yeah, and there we try to disentangle exactly these two dimensions. So we talk there about shocks where we just take out single doctors and measure properties of individual physicians. So because you can either, so to say, stabilize the system if others leave, or you can destabilize the system to a different degree if you are the one who retires or who for whatever reason moves somewhere else. Yeah, and so this is one type of shock, and the other shock is where we ask in the sense that I've shown here. So here basically these are here we have shocks where we remove 20%, 30%, 40% of the physicians at one individual time. And so the point is, you can compute system level indicators, regional indicators as shown here, which tell you how much doctors you have to take out of the system before you get troubles. But of course, you can also compute doctor level, physician level indicators in order to understand, so which are the one doctors that's maybe not so important if they leave, but others you should immediately replace, and this you should incentivize in keeping them in the system. And so both of these angles are possible, yes.
Okay, thank you. We can still take one last question in the chat. Fadi had asked, he's thanking you for the nice presentation. You mentioned that the way we construct network matters. So if the construction methods leading to the causality relation we discover, are they the construction methods leading to the causality relation we discover, like a self-fulfilled prophecy here, or are these used only for validation?
Yeah, no, I would answer this via validation. So the network itself, I mean, there is no true network. That's what I wanted to say. The thing becomes operational if it allows you to do some predictions better. And that's the value of it. So there isn't, the question is not, is this a good way or not so good way in measuring this network and constructing this network, but you always have to operationalize it. Can you answer this question better if you construct a network like that? So I would, it's like, so I think we need to get to a point where this kind of methods become, you know, as regression models are in standard statistics. So there is no true formal regression models. There are some formalizations of regressions that sometimes make more sense, sometimes less sense. And the community has gathered a lot of experience in when to do what. And I think similar learnings we have to do in network science in order to understand how we can operationalize these networks concepts in for different tasks, and to really make this more applied and more impactful. So when we really want to apply it, be it in an economic or in a healthcare context or wherever.
Okay, fair.
So the question of causality is briefly maybe. So yeah, of course there are this causal inference approaches and this causal network approaches. I found intellectually, I found this quite stimulating, I have to say, but having worked for this on a couple for I don't know, 10 years now that we're doing that, I haven't come across a case where it's easy that all these theoretical requirements to do causal modeling are really fulfilled. I mean, we can always say, of course, that a mechanistic model is in some sense a causal model, but then of course we also know that a mechanistic model is always constrained by the data that is available. I would even challenge the thing that thinking about this in causal terms is the most informative way, because that's what I wanted to make clear in the beginning. In many of the things, in almost all of the things that we've been looking at here, there is not one cause. It's a network of causes. Yeah. And this we have to. This is hard to notion with to marry with the notion of causality that we have in causal inference. For instance, we haven't seen an acyclic disease network. So, but yeah.
Okay, thank you, Peter. I guess we have no more questions, so I'd ask the audience online and in the auditorium to join me in thanking Peter for the very beautiful talk that hopefully will inspire a lot of our students to trying to think about networks in the context of healthcare systems. So hopefully, Peter, I don't know if that's going to be a possibility. We'll be happy to have you over with us on campus sometime soon, so we can plan a visit if that's a possibility. And thanks again. So
yeah, thanks a lot. Thanks for that nice discussion. And yeah, let's stay in touch.
Thank you.
Yeah. Okay.
Goodbye.
Bye.